Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to be talking about manipulations under anesthesia, why you might want to avoid this procedure, and then over the course of this short playlist, some exercises that are extremely helpful in avoiding that procedure. But before we get into that, let's get a little bit of background on why someone would even need a manipulation under anesthesia. Need one. So, first of all, this is most common in individuals following a total knee replacement. It can happen in other procedures, but it's a lot less common. I have seen this following an ACL reconstruction, but generally it's the total knee population. So here's the thing. Prolonged inability to achieve full knee extension and flexion increases the likelihood of significant scar tissue accumulation within the knee joint. So the longer that you are not moving the knee after the procedure, the longer that you let time go by where you're not able to push through these range of motion barriers, or you're restricted due to pain and not willing to push through it, the longer that goes on and you're not moving the knee joint effectively, the more time you're allowing scar tissue to build up. And the more scar tissue that builds up, the more painful and limited that knee movement's going to become, to the point where that scar tissue is so prolific within the knee that achieving full range of motion is pretty much impossible through normal exercise that would be given in a PT clinic. Now let's understand some reasons why this might happen. So first of all, I would never blame the patient first. Sometimes it may just be, and I've seen this before, the PT is underdosing or giving inappropriate exercises, okay? That's always a possibility. You should always look at yourself first. Am I doing this correctly? Am I doing what's best practice for the patient before start blaming it on other things? But there might also have been some type of complication post-surgery, and I've seen all of these. A blood clot or an infection. And I've actually had a patient where it was both those things combined. This particular person had a blood clot and an infection, and by the time he was able to get into physical therapy, he had the knee mostly immobilized for so long that that scar tissue had developed, and he ultimately ended up having a manipulation under anesthesia. There could also be a secondary injury that occurs. I've actually seen a couple of these. One of them, less of an injury, but the person developed a Baker's cyst on the back of their knee, and for whatever reason, that particular patient's surgeon would not drain it. And it ended up just limiting range of motion. It was so painful, and she ended up getting scar tissue development. And at this point, she has not had the manipulation, but it's very obvious that the scar tissue has accumulated. I've also seen another case where a patient somehow injured their IT band. At least that's what we think. They can't do an MRI because they have all this metal equipment in there, so they can't do that because of the magnetic field and so forth. But bottom line, she has all this scar tissue development, and again, as far as I know, has not had a manipulation at this time. And then also illness. I've seen this one actually in an ACL reconstruction. This particular patient was sick with influenza at the time of the surgery, and the surgeon was aware of it, and the surgeon went ahead with the surgery. Now, this is irresponsible for two reasons. One, by doing this on a patient with the flu, that surgeon could have contracted the flu and spread that to other patients that she was doing surgery on, or to other patients that she was not doing surgery on. So it's irresponsible for that. But also, when you're sick, everything hurts. Why is that? Because when you're sick, there's inflammation in your body. Inflammation is necessary to fight whatever the infection is, but that inflammation sensitizes the nervous system. The nervous system gets ramped up. That's why everything hurts, everything aches when you're sick. So now you're sick and you throw a traumatic procedure on the knee where they're going in cutting things up. The nervous system in that area was so ramped up after the surgery that she had no tolerance for knee bending. And she's a great example of somebody who actually did not get the manipulation, and we got full range of motion by doing what we're going to be talking about, hinting at the end of this video, but going over more in the next couple of videos. Okay, so there can be some kind of complication like that. But there's also the obvious one. They're not compliant with their HEP or with treatment in general. And I have seen this in my clinic. It wasn't my patient, and we tried everything to get this guy to do his stuff, and he just was lazy and didn't want to do it. And at one point, I think he was 20 degrees short of full knee extension. I don't know what the flexion was, but You shouldn't ever assume it's the patient, but sometimes it is, unfortunately. Now, you have a patient that's in this situation. They've had some kind of a procedure, scar tissue has built up, maybe knee extension's limited, maybe knee flexion's limited, maybe it's both. What's typically done? Well, the typical response by a surgeon is to recommend a manipulation under anesthesia, usually abbreviated in MUA. This procedure involves the surgeon arthroscopically removing scar tissue, and it's not all the scar tissue, because some they're not going to be able to get to, and then maximizing the passive range of motion while the person's under the anesthesia. And they wake up, and then typically what happens is they're required to go to physical therapy the very minimum 3 days a week. Sometimes they'll even push it to 5, because once you come out of that, what's supposed to happen is the PT is supposed to crank on the knee into flexion or crank it into extension, just really try to get that range of motion back to as much as possible following the procedure. The problem with this is that these MUAs, they just don't work, okay? If you go onto Google and you search manipulation under anesthesia NCBI, and you'll find some actual articles that do claim that they're effective. This is problematic because some of these are a little bit older. A lot of the newer papers are coming back and saying, you know what, they don't work that well, okay? And even some physical therapy schools are starting to teach that this procedure is just kind of junk. It's not effective, it doesn't work. And for anyone that's actually a physical therapist and seeing these patients come in after the manipulation, clinical experience tells you that it doesn't work. And I'm going to give you some reasons why here. So here's a paper that said the mean pre-manipulation range of motion was 80 degrees, and the mean post-manipulation range of motion was basically 100. Okay, so that's a 20-degree increase right there. And this paper actually went on to, in the conclusion, to say it's effective. You increase 20 degrees, it's effective. Here's the problem. If I asked you, an untrained person, so somebody who's never looked at this before, is a 20-degree increase good? Yes, and from a statistical standpoint, it was a significant improvement. The problem is that if you're an athlete, and presumably you wouldn't be getting a total knee replacement, most likely be ACL reconstruction, maybe even a meniscus repair, but you need way more knee flexion range of motion than this. A lot of athletes are pushing 130, 140, sometimes even more, depending on flexibility and the requirements of the sport. But even if you're just a regular old geriatric person who's not doing anything significant athletic, just doing regular ADLs around the home and community, functional knee flexion is 120 degrees at least. 120 degrees for any patient is the bare minimum we want. We want to get more than that, but 120 degrees is functional. This is still 20 degrees less than that. So clearly, maybe from a statistical standpoint it's effective, but for getting somebody maximal function, it is not, okay? And then there's two other papers that I found that kind of all say the same thing. The third one's a little more specific. The second one goes over a little more. But what you see here, number 3, is basically a statistically significant increase in the rate of non-infectious etiology revision TKA was found in the manipulation cohort. Long story short, what that means is there's an increased rate of revisions that have to be done, okay? And anytime you have to have a revision, it's obviously a surgery, which obviously requires anesthesia. In an older population, the less we can put anesthesia in their bodies, the better. There's a lot of surgeons who, when somebody gets to a certain age, they won't even do a surgery because the risks of the anesthesia in their body are pretty large. We want to minimize the number of surgeries. So first of all, that's another thing in the nail in the coffin on this. But also, patients who undergo the manipulation after a primary TKA, they're at a higher risk of revision, as we mentioned, worse long-term clinical outcomes, range of motion, and survivorship. That's pretty bad. This range of motion thing right here is actually really interesting because this actually coincides with what we see clinically a lot following these manipulations. So let's suppose you have a patient, total knee replacement, they're stalled in their progress, got scar tissue building up in the knee, and knee flexion is limited. All right, so they go in for the manipulation, and what do we say happens? They usually come in for PT like 5 days a week, Monday through Friday, to really, first of all, maximize range of motion gains and then to maintain them theoretically. So this was my patient. I was a student physical therapist. I hadn't even graduated yet. This is the first patient I ever saw that got a manipulation. And she comes in on Monday. I think she got the surgery Friday or Saturday. So she comes in, And she right off the bat had like 20 more degrees of knee flexion, and it was much less painful. I mean, if we pushed it beyond that, it was definitely, stiffer and got painful, but it was nothing like it was before the manipulation. And I saw this, and being a naive student, I was like, wow, this is a miracle. I need to be recommending this to really any patient following a procedure that has stiff knees. Well, naivety ensued. So I treated her, and on Tuesday, it was pretty good. Come Wednesday, and especially Thursday, that range of motion, it was stiffening right back up. The range of motion went pretty much right back to where it was. It might have been 5 degrees more, but it was something where if somebody asked me, hey, you could get 5 more degrees of knee flexion. Afterwards, it's going to be just as painful, but you're going to have 5 more degrees. Would I do it? And the answer is no. Right? I don't think going through another procedure just to gain 5 degrees and have the same amount of pain and pretty much just as much stiffness is worth it. Okay, and that profile of getting the manipulation, being fairly improved for maybe upwards of a week at the most, and then kind of just slipping right back to how it was, even with these types of stretches, that is very, very typical. So bottom line, the patients are generally back to their pre-manipulation range within a week of the surgery. From a clinical experience standpoint, these really don't work, and honestly, some of the newer papers that are coming out are justifying the fact that they don't work. So the question is, what should we do? Well, we need to break the scar tissue. End of story. You can do it arthroscopically with the manipulation, or you can do it with certain exercises. And you won't find these in the literature. As far as I know, I've created this. This is called an intermediate load long duration stretch. There is such a thing as a low load long duration stretch, and this is just usually used to stretch out tight muscles. Over a long period of time, usually more than 5 minutes, you use a low load to stretch the muscle. The problem is, scar tissue tends to be more resilient than muscles. Muscles will relax a little easier and they'll stretch a little bit easier. Scar tissue, you've got to use some pretty good force to break through them. So am I going to use 100 pounds, a high load? No, I'm going to use an intermediate load, something that would be a little much for most muscle stretches, but enough to break through scar tissue. And there's really 2 that I use. To facilitate more knee extension and get through that scar tissue, I use a backpack knee extension stretch. And for knee flexion, I use a gravity-assisted wall heel slide stretch. And I'm going to be showing those in the next 2 videos. We'll go over the technique, all the considerations, and these 2 work really well. They work really well on patients that have had a manipulation. They also work just as well on patients that haven't had a manipulation, which brings me to my last slide of the video. And this is kind of just a little simplified flow chart of why I think manipulations should not be done, okay? Again, got someone with a knee procedure, most likely a total knee replacement. There's complications of some kind, and they get scar tissue accumulation. So you can do these intermediate load long duration stretches, and you'll get maximized range of motion. A great example of this is the ACL reconstruction patient I was talking about. Because she was sick during the surgery, all those nerves were sensitized. She just didn't have for a while any tolerance to knee flexion. I think she was at 65 degrees of knee flexion when she should have been progressing into the next phase of the rehab protocol. That's not good. She should have been at 120. She was at 65. And the surgeon wanted her to have a manipulation. So we simply employed the knee flexion stretch. She was at full extension, didn't need that. So we used the knee flexion stretch here. And over the course of about 3 weeks, we got her from 65 to 125. All the scar tissue broke up. And now she has clean, smooth movement from 0 to 125 with no pain. These stretches work great. The other patient that I was thinking about to illustrate this other path is the guy that had a blood clot and an infection. He was immobilized for some time, was not able to do physical therapy, had scar tissue develop, and he was, in the end, short of knee flexion. So he went ahead and had the manipulation. And he was not my patient, but due to short staffing, I actually saw him for a couple of visits. The first time I saw him, we employed the knee flexion stretch, this gravity-assisted wall heel slide stretch. And there was a good 20 pounds on his ankle. 20 pounds is quite a lot. That's a lot more than a low load long duration stretch. This is intermediate load. And long story short, we tortured him for a little bit in that session. And he improved from about 105 degrees to 117 in one visit. There was scar tissue popping like that, popping. I gave him that exercise for homework. We saw him in a week and a half after that, and he was clocked in, coming in right at 120. No assistance, just active range of motion. And at this point now, he is doing strengthening, motor control, balance, all this stuff once you have maximized range of motion to maximize function. And then eventually he would be discharged. So long story short from this flow chart, somebody gets scar tissue accumulation, they're limited in extension, flexion, or both. They can either do these stretches and get maximized range of motion and then continue on with rehab and go about their lives, or they can go through the effort of scheduling a manipulation, getting that anesthesia put in their body, paying the money to do it, being a burden of cost on the healthcare system, but they're gonna have to do those stretches anyway. I'm sorry, but if you just get to 100 degrees like that paper said, it doesn't do anybody any good, okay? It's not functional, it's 20 degrees short of that. You'll have to do these stretches anyway to get to that maximized range of motion. This is not a silver bullet, even though some surgeons will tote it as one, as a backup. It's not a silver bullet. Just because you do this doesn't mean you're gonna get full range of motion. It's the stretches that occur after or even without the procedure that are gonna get you maximal range of motion. The MUA, the manipulation under anesthesia, bottom line is just unnecessary. And so in the next couple of videos, I'm going to be showing you how to perform these two stretches and some potential exercises to reinforce the range of motion gains that you will get with these stretches. So hopefully this video gave you a lot of good information on the manipulation and why you probably want to avoid it. Please make sure to like this video, subscribe to my channel, and hit that notification button for notifications for all videos in the future. Thank you so much.